Good morning, everyone. I hope you are enjoying this wonderful transition into fall. My name is Saxton-Ross, and I will be the moderator for today's panel, Ensuring Equity Across the Life Course. Please make sure as we're continuing, if you have any questions, we'll have about 15 minutes at the end for questions. So please make sure that you submit your questions in the chat, and we'll be able to make sure that we get to those. So again, my name is Saxton-Ross. I am on the Mayor's Commission for Health Equity. Currently, I am the Vice President of Education and Chief Equity Officer at the National Recreation and Parks Association. We have a wonderful panel ready for you today. We have a host of leaders that have really been preparing our city for health equity and making sure that we live and breathe health equity, not just in policy, but in implementation on the ground. So we'll be joined today by Dr. Arno at the DC Department of Health, Dr. McClaskey, who works also in the DC Department of Health and the Family Health Bureau Chief, and Dr. Elam, who is also on the Mayor's Commission on Health Equity and is the CEO and Plan President in Merit Group. And you'll get a little bit more information about them as we continue. So to give you an outline of what we're going to go over this morning is that we'll start with an introduction, make sure you understand our objectives for this morning and really frame our conversation. Then we'll move on to a more in-depth discussion about health equity in the district and the 9 key drivers of health equity in Washington, D.C. Then we'll move on to some specifics in maternal and infant health, really talking about how equity is informing the choices that we're making when it comes to maternal and infant health in the district. We'll move then into integrating equity, so what it looks like on the ground and how it intersects with healthcare and finance. And then we'll end with questions and answers. So if we think about ensuring equity across the life course, it's important that we continue to stay rooted in the social determinants of health and really think about how everything is health policy. All policies are health policy, and continue to have the conversation of not just health in the terms of health care, but health in the terms of where we live, learn, work, and play, and help everyone understand their role in producing health and making sure that everyone thrives in the district, including mothers and children. So let's start to connect the dots. Our learning objectives for this morning is to learn about the root causes of health inequities here in Washington, D.C., to understand the role of the 9 key drivers in creating opportunities for health, and to connect the dots, to know how persistent non-health inequities impact maternal, infant, and family health, and create barriers to health and equity across the life course. So we're going to go ahead and get started with our first presenter for this morning. Dr. Anneta Arno is an experienced public health professional with a track record in the field of health equity. She oversaw the publication of Louisville's 2011 inaugural Health Equity Report and the development and delivery of the updated version in 2014. She also, with funding from the Kellogg Foundation, convened, sorry.
Go ahead, keep him. That was me.
Oh. And with funding from the Kellogg Foundation, she convened over 100 folks from Louisville on healing possible quorum. She was appointed the inaugural director of the DC Office of Health Equity in September of 2015 and continues to leverage a health in all policies framework and was my former boss. So I would like to hand it over to Dr. Arno.
Well, good morning, everybody. Thank you so much for joining us. I'm really excited to be doing this work. The work that we do both in the district and the Office for Health Equity, plus the work that we do as part of the Mayor's Commission on Health Equity are really critical as we think about what drives health and the importance of the 9 key drivers. I'm going to go very fast. Really, what is different about an Office for Health Equity in the vein that we've developed is that we look what I call beyond healthcare and health behaviors. It's all the other things that drive our health outside of traditional thoughts about what drives health. So what is health? Health for us at DC Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So it's really a very broad, not health care or health industry kind of thought process. When we think about what drives health, we want to look beyond disparities. We also want to look beyond traditional notions of equality and move towards equity and what that means, towards what we call an equity-informed approach to population health. So you'll learn some more about it. I'm going to go fairly quickly, but the bottom line is that 80% of what drives our health has nothing to do with healthcare or our health behaviors. Only 20% of what drives health happens in the doctor's office. So there's a lot more work for all of us to do beyond what we traditionally think of as health. Bottom line is, if you hear nothing else from me today, here are the 6 things you have to remember. Key insights. Health is more than healthcare. Health inequities are neither natural nor inevitable. I don't know why it's. Your zip code may be more important than your genetic code for health. The choices we make are shaped by the choices we have. So that means that if the doctor says to you, you need to exercise, and you live in a circumstance where there's no place for you to exercise, or it's not safe for you to exercise, the point may be moot, is really what we're saying, right? So we may know what we're supposed to do. It may not be a real option. Structural racism acts as a force in the distribution of opportunities for health. And I'm going to say that again. Structural racism acts as a force in the distribution of opportunities for health. Very critical to know. Ultimately, all policy is health policy. So whether we make policy in transportation, employment, anywhere else, that actually impacts our opportunities to be healthy. So that's the most important things. We think about it in DC as being these buckets. So this is kind of a peeling back the onion a little bit. So you can see 20% are clinical care, but we can see the biggest amount of this, 40%, is social and economic factors, right? Education, employment, and income, and all of those things. But it's also more than that. It's what creates those differentials. It's the structural determinants of health. What causes these distributions in the first place that we frequently ignore? So we need to think up beyond that. So what we've done in this inaugural health equity report is to really think about these 9 key drivers, and I've listed them here. What is unique about how we've presented it, instead of simply staying at the 8 wards level, we've looked all the way down to 51 statistical neighborhoods. We've correlated the data in terms of life expectancy at birth. So it's a cross-cutting kind of way of thinking about it. And we're looking at the social and structural determinants of health. What that looks like is that if we start thinking about even how we live as a community, right? We know we are many years off, 50 years plus, since several things became illegal, but we still have race and ethnicity driving where we live. So in these 4 graphs of the district, what we're seeing is that predominantly non-Hispanic whites are living on the west side of the city. Non-Hispanic Blacks are living on the east side of the city. Hispanics are living up in the upper northeast. And then non-Hispanic Asians are kind of living more in the kind of around the parks and those kinds of things. So despite what we may think about what has happened in our city, we are one of the most segregated cities in America. And it would take literally 70% of us would have to move if we were theoretically trying to have an equal distribution. So that is the underlying driver. When I talked about structural determinants, that's really what is happening in terms of racial inequities. Frequently across the world, we can think of infant mortality as being a bead on the health of a community. And what we're seeing here in the graph on the left is that even though the orange line in the middle, everything is going downwards, everything is decreased. As we see in Anneta, halving of the amount overall of infant mortality, there's still significant differences. For African Americans, it's still 3 times higher, nearly twice of some, and 3 times higher of whites. We see significant numbers of preterm births, etc. And what we're seeing is approximately 44% of infant deaths to non-Hispanic Blacks are related to being born preterm, being born too soon. So that just sets the stage. If we look at the leading causes of death in the district, the 10 leading causes, we know it's very similar to the rest of the country. So heart disease and cancer take up 25 and 22%. But what we see distinctly on these two maps is that even though they are approximately about the same overall, we see different patterns by the 51 statistical neighborhoods. So everything is patterned in the district. I first showed you some of the things by race. If we look at accidents and injuries and Alzheimer's, we're seeing a different pattern. What we know is that accidents are happening to folks who have jobs frequently that put them at greater risk. And you only end up dying of Alzheimer's if you live long enough to have that benefit. So again, we're seeing a different set of patterns. So again, the issue here is really differential patterns of outcomes depending on whatever issue we're looking at. So I will now look, I'm trying to make sure my slides go forward. Yes. So ultimately, oops, that went too fast. Ultimately, if we bring all of the 10 top leading causes of death in the district, you put them all together, ultimately what you get is what you see on the left-hand side, that we have differential opportunities for health in terms of length of life. You can see in the reddest of the red statistical neighborhoods, people are living up to nearly 90 years on average, whereas in the pale, faded out places, we have folks in some neighborhoods living less than 70 years. And you can see it's less stark if we look at it how we traditionally have been accustomed to, but we're also seeing slight differences if we're so 21 years difference in life expectancy at birth across the district. We can then look at it in terms of those, what we call the 9 key drivers in terms of education. And what you're seeing here is folks with a bachelor's degree are predominantly skewed towards the west of the city. And if we look at folks who are living in poverty and with only a high school diploma, they're also skewed in another part. Overlaying all of this are the sizes of those red dots, which are approximating the length of life. And what you'll see, and I'm using this graph as the starting point, we're also seeing the bar graph in the center, that folks who have less than a high school diploma are more likely to report that they're in fear and poor health. And this pattern repeats over and over again. We know also that level of education, and we're not saying that people don't know, because remember I told you the choices we make are shaped by the choices we have. What educational attainment is a proxy for socioeconomic status. And that's really what is driving the clear connection between different health outcomes and levels of education. So we see that over and over. We can then look at employment, same kinds of patterns. People who live in some parts of the city have the luxury of 97% of them being employed. And in the other part of the city, we have places where we have up to 30% unemployment. And where we have 30% unemployment in those kinds of levels, we also have the shortest length of life. And we can see the bar graph in the middle that there's a clear relationship between people's perception of their health and their employment status. So all of these things repeat over and over again. Of course, employment is related to income, and we can see significant differences in terms of income inequality across our city in terms of median household income, as well as large concentrations of households who are living with incomes at 15,000 and below, and that correlation with low life expectancy. We can look at incomes, and we can talk about the district as being in our heads, we sometimes talk about it being a high income city, and on average, that is correct. Most people in the district earn, or households earn, more than 70,000 per year. But if we break it out by race, we see a completely different spread. And similarly, we can see differences in outcomes. So I guess I'm going to start with that, but basically you're going to see the same pattern. And so the issue here is a pattern that is related to segregation and related to differential outcomes. And when we look at housing, most of us who live here think, well, the housing is cheaper over in Southeast. But it also means that because they are on lower incomes, their proportion of income spent on housing is that much higher than the rest of us. So again, we keep seeing the same pattern over and over again. If we look at transportation and what you're seeing on these maps, the darker the brown are neighborhoods where people have lower access to a private car. We can also see on the left-hand side that where our public transportation primary routes and they centralize in the city, again, differential access not only to a private car, but to public transportation, and then with the red dots on the left. And I'm going to have to pick it up. If we look at food, we frequently talk about food deserts, but it's simply not just that. Some of us live in a food desert. Some of us live in places where we have multiple options, whereas others, we have simply limited or no options, or very, very few. The places that are showing up on the left-hand side in the bright red or burgundy, those are places or neighborhoods where there's neither a grocery store or they only have a convenience store. So again, the choices we have, especially if we don't have a car, we do have limited income, is that we are stuck with those choices is what we have. And so we can also see the extent of people's reliance on food stamps and that relationship to the right-hand side. So again, we can look at medical care. We know that there's a difference in people's access and use of public insurance. We can also map in terms of people's use, ability to speak English and otherwise, and we can look at differential outcomes in terms of life expectancy. But we also can see that even though overall in the district, we have relatively high rates of insurance, insurance alone is not enough. So yes, we may all have 97% on average, but we still see differential outcomes across the board. And I should have said earlier, we've put it into the chat. You can access the full health equity reports. I know I'm going through very fast, but the whole point of this presentation is to show you that what we've got is stark variation across the city. In a relatively small city, it's like 10 miles apart, but we're living next to our relative neighbors who are living completely different lives. If we look at the outdoor environment and we look at what kids are experiencing in terms of their exposure to asthma, et cetera, which is what we're seeing on the right-hand side, we're seeing that we have higher rates of asthma in the southeast and the eastern side of the city. And that's also correlating with different shorter lives. And I'll go to the next slide. Come on, yeah. If we look at community safety, which is number 9, we frequently only think about crime happening in the southeast, but really the highest rates of crime are actually in the center of the city. Violent crime and some other things happen in some parts of the city, but I challenge you to think about what is undergirding some of that stress and all of the other things that contribute to that, including suicides, which are happening all over our city. But a lot of these, what we think of suicide as also being a violent crime to ourselves. But this is, all of those things are contributing one to the other. So bottom line is, if we were to line up and list all of our neighborhoods by life expectancy at birth, and we look at all of the best outcomes, and what we've done in this table is done that, we can see if we look at the best outcomes, painted in green here, it's almost a full bingo across the board for the folks who have the longest life expectancy. But those who have the shortest, it's the same thing, right? The poorest outcomes are concentrated in the same neighborhoods, and then there's a mix in between. Ultimately, what that is telling us, it's not simply it's a rich-poor situation. Every one of us, because of the way opportunities for health are distributed, are given some modicum of opportunity somewhere in that continuum, 1 through 51 of the statistical neighborhoods. So what bottom line is, what we're seeing is that we have differential opportunities for health and interrelated pathways. There's a 21-year difference in life expectancy at birth. We have opportunities that show that the longest life are concentrated in opportunities in some neighborhoods. The shortest lives are also concentrated. But bottom line, it is clear that there are differential opportunities for health in the city by income, place, and of course, race. And that's kind of the end of my presentation, and I will hand over to my colleague, Dr. McCloskey. Thank you so much.
Hi, thank you for that, Dr. Arno. And so just quickly to introduce Dr. McClaskey. She is the Bureau Chief for the Family Health Bureau at the DC Department of Health here in Washington, DC, where she serves as the principal advisor to the Deputy Director and Senior Deputy Director on issues related to maternal and child health. In that role, she provides strategic direction And that includes in maternal health, newborn screenings, infant mortality, school health services, adolescent services, really anything having to do with the life course from birth for children and families. And as a board certified family medicine physician, she serves as a subject matter expert on several committees within DC and has over 10 years of experience practicing inpatient and outpatient medicine and obstetrics, pediatrics, and maternal medicine. And so it's so nice to be able to welcome Dr. McClaskey.
Thank you very much for that introduction, and good morning, everyone. Let's see, great. So I'm going to be discussing the Department of Health's approach to addressing maternal and infant health using a 7-stage life course approach. So it's helpful to kind of get the kind of background on the mission statement of the Department of Health, which promotes health and wellness and equity across the district. But specifically the Community Health Administration, we're working to promote healthy behaviors and healthy environments to improve health outcomes and reduce these disparities and the leading causes of mortality and morbidity in the district. So the framework that you see depicted here is an approach that began about 5 years ago to highlight the root drivers of infant and maternal mortality here in DC, with the recognition that this intervention, that if it focuses after birth or even prenatally, it's actually too late. So the framework is designed to improve perinatal health outcomes and is based on the overarching goal to ensure that every community understands its health risks and role in improving perinatal health outcomes. So you're going to see this bubble throughout the presentation, so I'll take a minute to go through it, as we've identified 7 core priorities that drive the programmatic efforts. So if you start at the top bubble in pink and work your way around clockwise, we have every teenage girl and woman is in control of her reproductive health. Every pregnant woman receives patient-centered, high-quality prenatal care beginning in the first trimester. Every healthcare provider has the tools and resources they need to provide quality care and manage complex social needs of women and infants. Every healthcare facility providing maternal and infant care has the tools and resources to practice evidence-based healthcare and to document quality improvement and quality assurance activities. Every newborn should receive high-quality neonatal care in the hospital and in the outpatient setting. And every parent should have the life skills and resources needed to nurture and provide for their family. And finally, every mom and dad has a safe and healthy environment to thrive and receive the support they need to promote early childhood development and learning. So this is the framework in which we're working with. So all of our work is driven by the data which is collected. So we can start by looking at some of the statistics, which you heard in the previous presentation. But specifically, if we look at the birth rate, we see a decrease from 15.5 in 2008 to 13.1 in 2019. Specifically for DC, if we look at the birth rate for women over the age of 35, it's actually increasing. But for women under the age of 30, we have seen a decrease. When we look at the total number of births in DC, it's around 10,000 for DC residents each year. So in 2018, we saw a little over 9,000 total live births. But when we start to look at the outcomes of these births, this is when we begin to see some of the disparities, which are based on the race and the place of birth. So the next couple of slides, we're going to look really specifically at pregnancy-related mortality in the District of Columbia between the time period of 2013 and 2017. So DC Health, we use these definitions of pregnancy-related death, which is defined as the death of a woman while pregnant or within 1 year after delivery, which is going to be depicted in the light blue, and maternal death, which is the death of a woman while pregnant or within 42 days after the delivery, which is going to be in dark blue. And we use this data to determine our policies and programs to prevent death, because during different time periods of death can relate to the different underlying causes, which is going to influence or maybe change our interventions that we're going to use. So as you can see, there's really the pregnancy-related death does fluctuate from year to year. And while 1 is too many, the total number of deaths during that time period is 20. So if we take a look at that center graph or the center chart in the middle, we see in 2015, we had a total of 7 pregnancy-related deaths as compared to 2017, where there was only 1. So I do want you to remember the number 20 as we move forward. So this next slide, we start to look at who is experiencing the deaths by race and ethnicity. And this is where we start to see some of the extreme disparities. So the pie chart on the top right has a total number of births in the district during that time period. And as you can see, about 50% of the births were to non-Hispanic Black women. And while just 1/2 of the births were to non-Hispanic Black women, 19 of the 20 pregnancy-related deaths, or 95%, occurred to non-Hispanic Black women. So this is in sharp contrast to non-Hispanic white women in the district who didn't experience any of these deaths. And the one remaining pregnancy related to deaths occurred in a Hispanic woman. Moving on to look at the number of pregnancy-related deaths by ward in which the mother resided. Again, we have on the top right that pie chart, which shows the distribution of births by ward. And we can see that there's an overrepresentation in wards 7 and 8 of pregnancy-related deaths. So 12 out of the 20 pregnancy-related deaths occurred in women living in that area. So in Ward 8 alone, they represented 40% of the pregnancy-related deaths. And when we look at the racial or ethnic makeup of the residents within Ward 8, we know that 92% of those residents identify as being African-American. The median income is about $35,000 per year, and 17.3% report being unemployed. Again, we see a big contrast with wards 2 and 3, where there were no pregnancy-related deaths at all. In Ward 3, 82% of that group identified as being white. The median income was $159,000 per year, and only 3.4% reported being unemployed. So we saw this graph in a little different form in the presentation prior, looking at the infant mortality rate if we move along our life course. And what we can see in green, we have the DC infant mortality rate, and in purple is going to be the US, and then in orange going across the middle is the DC Healthy People Target Goal in 2020. So in 2016, there were 70 DC resident infant deaths, which corresponds to an infant mortality rate of about 7.1. And really between 2012 and 2016, there hasn't been much of a change, with the average being around 7.8 for the infant mortality rate. But it's important to note that we are above the national average. So if we look at the leading causes of infant mortality, we do have to combine 2 years worth of data when we're looking at DC, which is in the middle or on the left-hand side, in comparison to the US, just because of the size of DC. And if you exclude accidents, the main cause of infant death in DC is related to maternal complications. And this is most commonly related to extreme prematurity due to premature rupture of membranes, which is in contrast to the US population, where congenital anomalies are the #1 cause. So does it matter where you are born? And so we've already heard is absolutely it does. So the dark green areas represent the wards with the highest numbers of infant mortality rates, and that's going to be 5, 7, and 8. So while these wards accounted for about 44% of all live births, they had 64% of all infant deaths. So if we continue along our life course and we look at adolescent health, and we want to be really careful not to assume that the only thing about adolescents is their sexual health. There are other things involved with adolescents' health. We can note some very concerning trends that we've seen. So this information is taken from the Youth Risk Behavior Survey that found that 1 in 12 middle school males reported having had sex by age 11. When asked within 3 months of sexual intercourse, did they use condoms? We had 18.1% of males and 23% of females did not use any method to prevent pregnancy during their last sexual intercourse. And we do see a declining rate of condom use. So only 67% of males and 47% of females used condoms. So what does this mean as far as us trying to break the cycle? We need to be familiar with the term intergenerational trauma and what that actually looks like. So historical trauma is multi-generational trauma. It's experienced by specific cultural, racial, or ethnic groups. It is related to major events that oppressed a particular group of people because of their status as oppressed, such as slavery, the Holocaust, forced migration, or even the violent colonization of Native Americans. And so when we think about African Americans specifically, they've experienced generations of slavery, segregation, and institutionalized racism that has contributed to physical, psychological, and spiritual trauma. And we know that the effects of this can be seen in utero. So women who've experienced maternal and prenatal stress, including psychosocial stress or maltreatment, have been found to be associated with having impaired uterine blood flow, low birth rate, and preterm birth. Individuals who were products of low birth weight or preterm birth in turn have been linked with having subsequent development of hypertension, type 2 diabetes, and cardiovascular disease in the adult offspring. So what that means is what you're exposed to in utero can actually increase your risk of getting a chronic disease later in life. So what can we do to approach this and address this problem? Well, from a public health department, we can utilize this 5-tier pyramid, the health impact pyramid, which really provides a framework to improve health on a public health stage. So interventions that are located at the top tiers are designed to help individuals versus the things down at the bottom of the triangle, which are going to have more of an impact on a broader level. And you heard Dr. Arno talk about all of these social economic factors. So if you look at the very top of the pyramid, we'd be looking at encouraging individuals to eat healthy and to exercise. Moving down the period, what's going to make a larger difference is going to be addressing the social economic factors such as poverty, education, and housing. Those are going to make the largest difference and the biggest impact in order to change some of the things that we're looking at. So you've seen this already. We talked a little about that. We have to connect the dots. This is going to be one of the most important factors in order to change. And I'm specifically talking about maternal and infant care, but on a systemic and a larger level, we have to be able to connect the dots and make the changes that we need in order to move the scale to better health outcomes. So we need to look at what we actually have in DC. And you can see this picture depicts a nice idea of what the investment into primary care and quality improvement has done, especially with the support of Mayor Bowser. So we know that we have 5 birthing hospitals and 1 birthing center within DC, and soon to have another hospital in Ward 8 that's going to be equipped to handle specialty maternity needs. We have primary care and prenatal care capacity across all 8 wards, including federally qualified health centers. We do have one of the highest medical insurance rates in the country, about 97%, only secondary to Massachusetts. We have one of the most robust Medicaid programs in the country and one of the highest provider-patient ratios in the country. So these are all positive things that we have. If we look specifically at some programs that are invested in mothers and infants' better outcomes, this is just a snapshot of what we have. We have the newly established DC Perinatal Quality Collaborative, and this network of health professionals is going to be working together to participate in data-driven quality processes that are going to help improve maternity care. We have the Title V Maternal and Child Health Advisory Board, and this group meets to convene and discuss the needs and programs related to maternal and infant care. We have the Child and Infant and Fatality Review Committees. We meet monthly to discuss systemic changes that might be put in place to prevent future deaths. And we have the newly established Maternal Mortality Review Committee. And this group meets not only to just go over the data, but to really assess the relationship between the causes of death for our women. We also have the Youth Advisory Committee or Council, and this is actually bringing the youth and adolescents to the table to discuss their own issues and what might need to happen to break the cycle at that stage. It's promoting health and building leadership skills, and it's empowering our youth to become effective advocates and competent public health educators. And we also now have the law on our side. So together with the support of the mayor, DC Health created a comprehensive legislation. It's the Better Access for Babies to Integrated Equitable Service Amendment Act of 2020. And what this mandates is for all hospitals to report newborn metabolic screening testing, hearing, and critical congestive disease screening. In addition to that, they're going to be mandated to make sure that we have protocols to support lactation services, education requirements for newborns and postpartum health, standardized discharge regulations, and clinical quality measures for obstetrical and neonatal care. Any of the hospitals who are unable to comply with this could be subject to civil fines and penalties. And lastly, we want to make sure that we have established a perinatal infant advisory committee that will report to the DC Health Director and the mayor on different initiatives. So very, very briefly, this chart, you will see it again in our next presenter, but it demonstrates DC efforts to address pregnancy-related mortality using the 5A strategy to address the social determinants of health in the communities. So the things listed in black are the suggestions, and what's listed in blue is what DC is actually addressing already. So if we look at the first category, which is awareness, We're already collecting data on maternal mortality systems and comparing them to a national level. The second bucket would be adjustment. The recommendation is to implement standardized protocols and quality improvement initiatives. Well, we're doing that by the utilization of telehealth to conduct healthcare visits and funding and supporting programs that are doing that, as well as our hospital discharge regulation protocols that will be put in place. Under assistance, the recommendation is to ask the needs of patients, their social needs, and have them participate in their own healthcare. We're doing that with listening to the youth and the advisory council and the perinatal quality collaborative group. In alignment, the suggestion is to identify and address implicit bias in the healthcare system and give support to our providers. And we're doing that with the use of our advisory boards in the maternal lab, which wasn't mentioned on the previous slide, but it's work in conjunction with the DC Primary Care Association to explicitly address implicit bias in respectful care. And then lastly, the recommendation for maternal mortality review committees. And happily, we can state that we now have a DC maternal mortality review committee as of 2019. So are all these things making a difference and kind of breaking the cycle? And happily, we can say that we have seen some changes. If we specifically look at our adolescent group, we can see that the teen birth rate has dramatically declined for this age group between 15 and 19 over the last decade. We've seen a decrease in alcohol, tobacco, and illegal drug use. And we also have seen violence and victimization and violent behaviors among high school students are trending downward. And if you remember the graph for the infant mortality rate, it does continue to trend downward. So we are seeing a difference trying to break the cycle with what we're doing. So what are our next steps in this space? Well, we need to continue with our collaborative efforts across all sectors. It's going to be important for us so that we are not duplicating efforts in order to close the gaps and make sure that we are really strengthening our robust evidence-based programs that are making a difference, to make sure that we are changing the outcomes and eliminating the inequities that we see so that we can improve the health of all our district residents. Thank you.
Thank you, Dr. McClaskey. And last but definitely not least, we have Dr. Linda Elam, and she is a health policy and management leader with deep experience in financing and delivery of healthcare in vulnerable populations. Presently, she is the CEO and plan president of AmeriGroup, District of Columbia managed care organization serving the Medicaid population here in Washington, D.C. At the state level, she has served as Senior Deputy Director for the State Medical Director and helped develop and implement the programmatic changes related to the Affordable Care Act, including Medicaid expansion and the initial work to establish the district's health benefit exchange.
Thanks so much. I'm having a little bit of trouble with my screen here, so.
It says Makita will advance for you.
Okay.
Temporarily.
All right, thanks. Well, thanks again, Dr. Saxton-Ross, and it is a pleasure to be with you all this morning. My section of this presentation will review the framework, the 5A framework that you just saw for integrating social care into the delivery of healthcare. I'm going to briefly outline the importance of Medicaid as a health equity intervention, and discuss the role of Medicaid in maternal and infant health, and then provide some on-the-ground examples from AmeriGroup. So thanks. Dr. Arno presented the evidence that overall, healthcare is not the primary determinant of health, and that health happens where we live, learn, work, play, and age. And then, as part of her presentation, Dr. McCloskey provided an example of addressing pregnancy-related mortality through the National Academy's Consensus Study Report Framework. And that's what we're looking at right now a bit more closely, the 5 A's. And so you'll see that it centers around awareness. If you could go back, I'm sorry. I think maybe I can control now. Can I? Let's see. Okay, maybe not. The 5 A's begin with awareness, and then you'll see that they break out into mainly individual level interventions or community level interventions. And that's really important for looking at a variety of ways to approach some of these issues. Next slide, please. So again, beginning with awareness, identifying social risks and assets of patients and populations. And then those first two, the adjustment is modifying plans to meet needs, things like extending office hours or having language appropriate services. Assistance is connecting people, providing that warm handoff, if you will, between healthcare and social care. And then the next two, and I will move really quickly because I'm trying to buy back some time. I know we have some really good questions, so forgive me for kind of breezing through. On alignment, you're going to bring healthcare resources together with the social care resources. And so, for instance, a health system might invest in transportation, understanding that transportation is a barrier to accessing care. And then moving further upstream, you can engage in advocacy that looks at how to reconfigure the system altogether to better serve the people that you are caring for. So next slide, please. So here's a quick example, and here's the document that we're citing. I highly recommend it because I think you've heard a lot of compelling information indicating that in order for us to get to the health outcomes we're looking for, we really need to link healthcare and social care. And this is a transportation example, walking through, again, those individual level issues and then the community level issues. Once you have an awareness of what some of the barriers might be or where some of the assets and strengths might be. Next slide, please. So moving on to Medicaid, it's a critical player in perinatal health across the country and certainly in the district as well. It's a federal-state partnership providing health coverage to people with limited incomes and some people with disabilities. In maternal and infant health, Medicaid is a key player nationwide, covering over 42% of US births, but definitely a majority of births in the District of Columbia, over 60%. I'd like to also note that the district operates the DC Healthcare Alliance, which is a very critical source of coverage for people who would otherwise qualify for Medicaid, but for immigration status. The district's progressive stance that you've heard about with regard to health coverage puts us in the top tier of states working toward full insurance coverage. But as you've heard repeatedly, clearly that is not sufficient to achieve health equity. So we have to do more and look at how we can use Medicaid to provide the care that our populations need. So an acknowledgement of the importance of Medicaid to perinatal health is the set of requirements around it. So for example, pregnant women must be covered up to 138% of the federal poverty level for up to 60 days postpartum. Most states do go higher. I would note, though, that for states that have not expanded Medicaid through the Affordable Care Act, after that 60 days, eligibility can drop as low as 17% in Texas or 18% in Arizona after the 60 days are up. That leads to greater rates or higher rates of uninsurance for women in the extended postpartum period when needs for physical and behavioral health can still be significant, as we just heard. But again, this is not a concern in DC. Pregnant women are covered over 300% of the federal poverty level. Beyond the number of people insured, the scope of coverage is really important. And again, I won't go into detail, but the guarantee of a package of core services is critical to Medicaid coverage. Core services are provided to pregnant and postpartum women. And in addition, the child health benefit, known as the early and periodic screening, diagnostic, and treatment benefit or health check in the district, is tremendously important for preventing and identifying clinical issues in children. Next slide, please. So Medicaid is largely run through managed care. That's nationwide, and largely through risk-based managed care, where managed care organizations or MCOs are paid a set rate per member per month to provide care to an enrolled population. And this is known as capitation. And one of the key principles behind a well-operating program is that by improving the health outcomes of the population, the MCO is financially sound and the population it serves is better off. As states are driving toward better health outcomes overall, they are asking Medicaid MCOs to focus more on the social determinants of health, such as housing, nutrition, education, and employment through screening, through making referrals, partnering with community-based organizations, and other mechanisms. And this is important because typically these are not the kinds of things that Medicaid covers. But again, because Medicaid MCOs are given a per member per month rate, they're able to provide the clinical care, but also invest in some of these social care modalities that we know can help improve health outcomes. And some of those are known as value-added benefits, and we'll talk about those a little bit later. Next slide, please. So very, very quickly, the 5 A's regarding pregnancy awareness. We're asking here the March of Dimes one key question: would you like to become pregnant in the next year? And again, there are the individual level pieces, the adjustment and the assistance that will help that individual achieve her goals. If she doesn't want to become pregnant in the next year, ensuring that she's got the right family planning tools available, that she's got the right coverage to pay for those or permit her to get access to those treatments, scanning for social determinant of health needs, and also critically behavioral health needs, including substance use disorder. So individual level issues are on the left, of course, and then on the right, looking at alignment, working with the CBOs who are very familiar with the population and the resources that are available, partnering with governmental agencies beyond Medicaid. If you're looking at something like housing insecurity or food insecurity, there are other alignments to make there. And then advocacy, working overall to promote policies to improve access to reproductive health coverage and payment for social determinants of health treatments. Okay, next slide, please. Kind of rushing because I know we are really tight on time. So if I take it directly to AmeriGroup as a health plan serving the district for 3 years, in order to combine that clinical care and the social care that we know we need to have working in tandem to improve health outcomes, we need to look at population level data, such as what's developed by both the federal government and the district government. Also, we have a community resource link where we get feedback as we see what our members search for in terms of social needs that they might have, education, for example, food insecurity, and so forth. And then that can be aggregated. On the individual level, we have case management data that are compiled, the outcomes of screenings and assessments, and then outside referrals as well. Next slide, please. And so this work is done through a very wide scope. As you heard, it begins preconception, and then prenatal care is critically important, postpartum care, infant care, and then outside of just that, clinical care, looking at that as addressing social determinants of health at the same time. So a big piece of that is enrollee education, which we invest quite a bit in. Provider engagement, education, and providing incentives to providers to engage in the evidence-based practices or the activities that we believe will lead to better health outcomes. Care coordination and case management, particularly for those enrollees with higher needs, chronic conditions such as diabetes or heart disease. And then the value added benefits, as I mentioned, the kinds of things that Medicaid typically wouldn't pay for, breastfeeding support kits, mail order diapers, a safe sleep kit to help address the SIDS issue that includes education and a bassinet, medically tailored meals where appropriate. And I'll just leave the value-added benefits conversation with something that we developed as a result of dealing with the pandemic in partnership with Mary Center, an OB telehealth kit that would allow a pregnant woman to provide certain data points through telehealth to her provider so that she could stay connected to care even while people were not generally going in for preventive care. So being responsive to what's going on in the environment, but at the same time, keeping people connected to care. So that was sort of lightning round. Appreciate the opportunity, and I will now open it up for the questions that I know have been rolling in.
Yes, thank you. Yes, and I'm not on mute. Excellent. Okay, so we have a few questions. The first one, I'll start with the easy one, and this is for Dr. McClaskey. Can you please place in the chat for our support team to give out to the audience how to, if folks have people for the Youth Advisory Council, can you please make sure that you send that information for the audience to be able to support young people into becoming part of the Youth Advisory Council? So that's—
Well, let me just interrupt there. So I'm excited to hear about the interest in it. It actually is a selection process. So you're not able to just kind of join it, but it is actually a selection process and an application process that occurs every year. So I can provide information indicating to go to DC Health to look up some of the services that are being done. But we are very excited that we've selected our group for this year. And so we'll be looking to look for new applications for the following year.
excellent. So we'll make sure that hopefully Makita can send them to the DC Department of Health's website to be able to see the application process. Okay, wonderful. So a question that I wanted to talk about, we have a couple of questions around teen parenting. And so if we think about the declining levels, how can we continue to support the health of adolescents, young adults, continue to support those teen parents, and thinking about how can we support folks to break the cycles of intergenerational trauma and really promote positive maternal health outcomes in the future. So what are some of the things on the ground that are happening or we are looking to continue to do to really help young folks when it comes to a lot of these, a lot of the issues for around health for adolescents and young people?
Well, I know Dr. McCloskey will jump in, but I thought I'd just preface the conversation with that it's even before we get to that point where we have young parents, we really, my whole presentation about it being, I usually say health equity is everybody's work. I know, for example, we have high schools in the city where the graduation rate is 50%. That means that year on year, we also know that for people who don't graduate from high school, they're probably going to live 5 years shorter. So I think there's a huge role for all of us as parents, advocates, and all of the other things, and those in the education field, to really think about how important it is for us to invest in the education of every kid in our city and make sure that they have all of those things as a starting place. So that would be my starting place. And then I'd hand it over. I think Dr. McCloskey talked really well about, having those young folks who come in and talk about how it would improve for them. but then I'll hand off to others. But I really wanted to make sure that we think about it in the bigger round than simply when we come to the point of being a consumer of healthcare. It's much more than that. So I'll invite anybody else to jump in.
Sure. No, I will just add to that. Absolutely. So if we're specifically looking at adolescents in that very precious time space, we do need to talk to them about what their specific needs are and really providing role models for them so they can see something different from what they've already seen. Earlier in the weeks, Dr. McCloskey mentioned talking to them about what is right with you as opposed to what is wrong with you, bringing them to the table to let them recognize that the things and the choices they're doing can infect them long term, and giving them the tools and empowering them to become advocates for themselves and public leaders. But in order for them to be successful, back to Dr. Arno's point, we have to give them the resources. So we have to provide them a space so that they are able to do the things that we are encouraging them to do. But I think really listening to them, hearing their voice, and encouraging them to think outside of what they think their norm is and shoot for other things that are going to inspire them to be healthy.
And I'll just add briefly, and so operationalizing that at the health plan level can involve, if someone needs assistance to get a GED, we can help provide that. We have educational opportunities that are also group opportunities, and there can be a significant amount of support that, that folks can provide to one another. And again, I'm kind of a proselytizer about really keeping behavioral health front and center as we think about physical health, and making sure that we're also, while we're worried about, the reproductive health side, that we're also considering the behavioral health side for young folks and attending to their needs there as well.
And I would encourage that, and the mental health support that they need, especially during this time period, is really going to be very critical that we're able to provide them with that sort of support, not just physical, but mental, spiritual, right. The whole package.
Thank you. And we only have 2 minutes left, so I'm going to try and throw in a question. When most of our conversation has been around maternal and infant rates as it relates to African Americans. But if we think about on the ground, what are some of the activities that are happening or specifics when it comes to the situation and issues experienced by Hispanic mothers and those that are pregnant? Do we have specific activities focused to help with those rates as well?
I can jump in, kind of going in the opposite direction right now, starting with how it works on the ground. Certainly serving the district, a very diverse community, health plans absolutely have to have culturally sensitive and linguistically appropriate services. And so that involves everything from printed material to classes that are operated to the case management staff that's working with those populations, and being a part of the community as well, bringing in staff at the health plan that really know, that are deeply rooted in the communities that we are serving is tremendously important as well. So that speaks to, the Hispanic Latino population, but other populations as well. And it's critically important in a diverse environment.
All right, thank you. That was perfect. We are actually right at 11 o'clock. Thank you. So here's everyone's contact information. If you'd like to follow up and ask any specific questions, thank you so much for joining us this morning, and enjoy the rest of the conference.
Thank you, everyone.
Thank you, everyone.
Thank you.
Bye.
Thank you so much for listening.